So, good evening, colleagues. We are starting the program, and we'll just invite our presenter to take over the stage and start the presentation. Dr. Okai, over to you.
Good evening, Dr. Kwashi. Good evening, everyone. Today I have tried to change my position, and my prayer is that we'll have a good network. Let me go ahead and share my screen. So good evening once again. Today is day 3 of our Gamls Cpd training. And I want to once again send out my utmost gratitude to the Gamls executives for organizing such a wonderful program to educate us and then having me to facilitate as well. All right. So today we are treating culture of body fluids, and we are looking at urine and then aspirates and exudates. So by the end of this session, we expect that we'll know how to properly collect urine samples for culture and how to process them. And since aspirates are not collected by laboratory scientists, we will know how to process them. All right. So by way of background, UTI or urinary tract infection has 2 main forms. It can be descending, where in a patient who has blood infection, bacteremia, or sepsis, as the blood goes through to the kidneys to be cleaned, bacteria ends up seeding into the kidney and then gradually going down to cause an infection in the urinary tract. And that is what we call descending UTI. And then we have the ascending UTI. This is when bacteria that colonizes the urethra rise up through to the bladder, causes infection there, rise up through to the ureters and then to the kidneys to form infections. So the most common type of UTI is the ascending. And usually the source of those infections are from enteric bacteria, from the environment, through instrumentation, and even through sexual intercourse. Ascending UTI is elicited. So it starts by colonizing the urethra, going up to the bladder, and then you get cystitis going up to the urethra, where we get urethritis, and then climbs up to the kidney, where we can get kidney injury or pyelonephritis. Now, so we have 2 forms, the upper UTI, which is the pyelonephritis and the urethritis, or the lower UTI, which is the cystitis or prostatitis in male, and then urethritis. Often it is caused by sexually transmitted disease. The key to diagnose urinary tract infections, cystitis, pyelonephritis, urethritis is urine culture. Okay, so urine culture, like we have said, can help you identify the bacteria. It can help you, first you establish it is present, you identify it, and then you find the drugs that can help in their treatment. But let us bear in mind that urine culture is usually a follow-up from a dipstick or what we call urinalysis, a dipstick and microscopy test. So in the dipstick, usually, or sometimes, we have nitrites showing. It's not always positive. And then we have leukocytes showing as positive. There can be low-grade proteinuria. So those are indicative of presence of a urinary tract infection. During the microscopy, hematuria, presence of blood in the urine, is suggestive of UTI. And then pyuria, or presence of bacteria in urine, also, when you are doing microscopy, is suggestive of UTI. Most common culprits of UTI or etiological agents of UTI is E. coli, Proteus species, Candida, just to mention a few. Now, I put this here. I think it will make more sense when we go down. In urine culture, when we are checking for white cells, it is best to use unspun fresh urine, because you want to see what is happening in the bladder without any interference. Centrifugation will push the cells down, and so you may not have a true reflection of what is happening there. But for urine culture, the ideal form of looking for pyuria is using unspun urine. How do we collect urine for culture? The specimen container should be a sterile, tight, and screw cap container. So it is a type that you can screw to cap it. And then this one here, usually we see them in the sputum labs for sputum culture or sputum AFBs. This is not ideal for urine culture because the cap is not secured enough. And so you can contaminate the urine sample. The urine can spill, contaminate around. Equally, it can be contaminated. So if you are this is brought to your store, kindly take it to where we do AFB culture, AFB for sputum, but not for urine culture. Usually 1 to 2 mL of urine will do for the tests. And then the type of specimen, we expect that the urine should have been in the bladder for about 2 to 3 hours prior collection. And so people advocate first morning urine. However, random urine specimen can also be used for culture. Now, the collection methods, this is where we have to be very particular, because a bad sample is equal to a bad result. So first and very popular is the midstream or clean catch urine. Here, the client is asked to wash the hands and make sure the container is still intact without opening it. And then in a female, either with wipes or soap and water, you wash the labia area very well. And then you pass a few mils of urine. This is to flush out whatever is in the urethra. As we have already said that the urethra can have bacteria colonizing there. And if they are able to climb up, then they cause a UTI. So when you're collecting sample for urine culture, you need to flush out the urethra by letting the patient pass a few urine, then quickly opens the container, opens the labia without the container touching his or her skin, produces a few mils of urine, quickly caps the container, and then finish up with the urine, washes the hand, and then presents the sample to the lab or to the ward, and then the nurse at the ward. In infants urine collection bag, there's an adhesive at the end. I have not seen one, but I believe we should have some organizations at the urethra side of the baby, and then you'll be monitoring constantly till when urine comes through, and then you quickly dispense this in a sterile container, the lab test to be done. Then we have suprapubic tap. And this is done when it can be, so it is done by a trained medical personnel where a syringe is passed through on top. Into the bladder to a trained person. Hello, did I go off or?
Yes, you went off. It means that you have to reposition yourself very well so that you don't go off again.
I have to go back to where I was. A few minutes to reposition. Okay. All right. So I was saying that for the catheter urine, we need to advise our clinicians and our nurses. I'm sure some of them will know, but we should also be in the know and give good advice during the collection of this sample. The person is already in catheter, so the urine has been standing for some time. So if you go in and take urine from the catheter bag, it is a very bad sample. You have overgrowth of bacteria. If you take urine from the tubings here, the tube, any part of the tube, you have very bad results. The best way of collecting urine from the catheter is if it is already in place, you drain the urine all the way from the tube into the bag. Drain it and then clamp it. Clamp it. The nurses know how to do it. But once you tell them, they know that truly we want them. We want this type of sample. So you clamp the catheter tube and then allow some time, 10 to 15 minutes. You check and see if there's fresh urine in the tube here. And then with a syringe, you aspirate the urine through the catheter ports and take it into your sterile container. This is one method. Another method is when you are now coming to give a fresh catheter. So for that one, the nurse does all her aseptic techniques. And then once the catheter is inserted, she allows about 15 to 30 ml of the urine to pass out. And then she can collect the other parts into your sterile container. So for catheter urine, we don't take urine from the catheter bag. We don't take urine from the tubings. If you want to take a urine, it's either a fresh catheterization, or if it is an old catheter, you drain all the urine out, clamp it, allow fresh urine to come in less than 10 to 15 minutes, and then you can aspirate into your sterile container. All right. Now, the sample should reach the lab within 1 hour of collection. If you foresee that you cannot work on it, you put it in a fridge at 2 to 8 degrees Celsius for about 18 to 24 hours to work on it. And then as you are transporting the sample, it should be in a biohazard bag. So like I said, a good sample is equal to a good result. A poor sample, poor collection method, poor transport or handling of the sample will lead to a bad result. What are the indications, or what are some of the things that will make a physician request for a urine culture? You know, in our labs, on our lab request forms, we have diagnosis or patient information. It is the lab letter between the doctor and the lab scientist, because we hardly see the doctors. It is just a request that gets to us. So whatever the doctor puts on the request form is vital for you. So you may not see the patient, but if the patient is a female, you know that, okay, fine. Females have a short and broader urethra and have more risk of getting UTI. If it is a child, there's this condition called vesicular urethral reflux. So when the urine is produced from the kidneys into the bladder, there's a deformity that some children have, that the urine will go back. It cannot be emptied. It goes back up through the ureter to the kidneys, and this can lead to infection. Also, if the person is pregnant, there's incomplete emptying of the bladder. So there's always residual urine for bacteria to grow. And if the person is diabetic, there's glucose in the urine, which bacteria love to thrive on. Now, for urine infection, anything that will cause stasis of the urine through any part of the urinary tract. So urine is moving from the kidney through the ureter to the bladder, through the urethra out. So anything that will hold the urine or cause the urine to stop flowing or cause stasis, reduce flow of the urine. Let's all just think of when you keep urine in a bucket or in a bowl for a long time, for a few minutes, how pungent and bad it smells. So in the same way, as you keep the urine from moving through its roots, bacteria can multiply quickly, and ascend and cause bacterial infection, UTI. So anything that will cause stasis of urine, so like in pregnancy, there's incomplete emptying of the bladder. In kidney stones, it can occlude some pathway. In benign prostatic hypertrophy, in men, you can see that sometimes there's stasis, so they can get UTIs. Any form of tumor that will block it, you can get UTI. So when you see these things on your request form, it's like a light comes up. Aha, I should be looking forward to getting something interesting. If the person has stroke, usually there's a neurogenic bladder. The nerves cannot contract the bladder to release the urine, and so the urine is packed in the bladder, causing UTI. So there are lots of indwelling catheter. Once the catheter is in there, bacteria can form a biofilm around it and then cause UTI. So when you see some of these things on your request form, there are a lot of them, but when you see some of these things on your request form, your antenna goes up as a medical laboratory scientist that I can get a UTI here. So some of the symptoms that the patient may present with is urgency in micturition, burning, paining after micturition, frequent micturition, cloudy urine, or hematuria, bad smelling urine. We have spoken about them already. So if I want to prepare or work on a urine culture, I need my microscope for microscopy. I need incubator to incubate the sample. I need a hot air oven to prepare my media, and I need a Bunsen burner or a bacinator to do my sterilization of my loop. The media for urine culture, you can use either clad, or when you don't have clad, you can use a combination of blood agar and McConkey agar. The blood agar will support, and the McConkey will differentiate GNRs for you. You can also use the chromogenic agar that we spoke about yesterday. And when you are suspecting fungal growth, you can use your sabrodextrose agar. You also need sensitivity test agar for your sensitivity. That is, if probably you go ahead and do it. Then the peptone water citrates, just to mention a few. You need your antibiotic discs. You need your plasma saline. You need your gram stain sets. You need cover slips, slides, forceps, ruler. You need, very important, calibrated standard loops, one on 500 or one on 400 mil. You need pasta pipettes, test tube racks. This will help you with your tests. So on your first day of receiving a sample, I don't know, the setup in the lab, maybe you have a reception or the sample comes straight to the lab. So once you get a sample in the lab, you have to sort it out. Make sure that the sample belongs to the patient. The name on the container matches with the name on the request card. And then once you are certain and you are sure it is a urine sample, but not any other sample, because some samples can look similar. Urine can look like aspirates, and so you have to be careful. Now, in the logbook, you put your patient details and you assign a number to your sample. Then you process the sample immediately, or if you cannot, you keep it in the fridge for 18 hours, 24 hours, like we have said. So day one, hey, this shouldn't be macroscopic ID. So day one, you have your urine sample. You inoculate your urine sample onto cleared cysteine, lactose, electrolytes, media, and then you incubate it at 37 degrees Celsius overnight, and then you perform your wet preparation, or you pick a few drops of the urine sample on a slide, cover slip, and then you examine under the microscope. Bear in mind that we said for the urine sample, it is best to look for pyuria when it is not spun for culture. Also bear in mind that before you plate your urine sample, you have to swirl it, mix it gently, not to invert it up and down, but mix it gently before you inoculate and do your microscopy. Now, how do we streak this urine sample on the media? There are several types of streaking methods in medical microbiology. And one of the methods is the quadrant streak. So streaking is what we call mechanical dilution. We are thinning out the bacteria. So if you pick up an inoculum, you put it up here. This is your first contact. You flame your loop cam, go in, second, third, and then fourth. So you are thinning down the load of bacteria from the first point of contact on the plate. So after I get something like this, this is the first inoculum. See how heavy it is. You can't see the isolate bacteria. The second one, the third one, and then the fourth one. If you remember last time when we were talking about the media, I said one cleared can be used for 4 urine samples. It is for economic reasons. And so because of what we call the continuous streak, so you touch the urine on your inoculum without coming to the end, go back. It is also called Christmas tree streaking or the continuous streaking. And so with this, you can push this in one corner, divide your plate into 4. You get this one corner, another quadrant here, another here, for your urine culture. If your lab is rich enough, you can use a whole plate for urine culture, which I don't advise. Anyway, day 2, after incubation, you come and examine the plates for evidence of growth. As you're examining the plates, you are determining whether it is significant or not. And we will talk about that as we go down. So you come, you see your plates, there's growth on it, it is significant. You go ahead and perform your gram stain. The gram stain will tell you whether the bacteria or whatever you have grown is gram positive or gram negative, or it is a candida. You'll get that information from your gram stain. And there is the need to do this gram reaction because it will help you in knowing which lane to go in identifying your bacteria. because there's a path to follow in identifying gram-positives, and there's another path to follow in identifying gram-negative bacteria. And so your gram results will tell you to do this array of tests whilst for gram-negative, whilst this array of tests is done for gram-positive. This helps save costs. This makes you shoot whilst aiming. You don't just shoot anyway. All right. After doing your biochemical tests, you go ahead and do your AST. Now, you do this only when your growth is significant. You do this, you do your biochemical testing and your sensitivity only when your growth is significant. On the third day, you come and read out your biochemical tests to help you identify the bacteria. And then you read you measure the zone of inhibition on your AST to see which drugs are sensitive, which drugs are resistant. And then you go ahead and validate the report according to your institutional protocol and then dispatch the results out. So how do we interpret urine culture? It is paramount to always interpret urine culture results in conjunction with clinical signs and symptoms of UTI. And we'll get to know why later. So for the clean catch or the midstream urine, we can get no bacterial growth. A growth which is significant, that is a growth less than 10 to the power 5 colony forming units per mil. So when you come to the bench and then you see that your growth is less than 10 to the power 5 colony forming per mil, you say it is not significant. Sometimes you can get polymicrobial growth, 2 or more isolates, and some of them are significant all over. This is likely of contamination. You don't know, I mean, the body will not suffice or tolerate this polymicrobial. It is definitely contamination. And so for that, you call for a repeat. Then we come to the significant growth. This is when the growth is greater than or equal to 10 to the power 5 colony forming units per mil. So how do you calculate this? So you are using a loop of 1 on 500 mil. It is the same as 0.002 mil. So this 0.002 mil, you used to pick the urine, but it says that for urine to be significant, it should be 100,000 per mil. So if 1 mil is giving us 100,000 colony forming units, then with your 1 on 500 loop, you're expecting a growth of 200 colony forming units. Or with your 1 in 400 loop, you're expecting a growth of 250 colony forming units as significant growth. And this must be reported with the AST. This must be reported with the AST. Now, for suprapubic tap, we dodged the urethra, which is the colonizer. We dodged the urethra, we dodged all those things and went straight to the bladder. And so because of that, any pathogen you see there should be considered as evidence of UTI. For the straight catheterization, growth less than 10 to the power 5, that's what I explained as the first time of putting on a catheter. You go in and then you drain the urine and then take some. So for that one, when the growth is less than 10 to the power 5, it may still indicate UTI. So if you don't have that diagnosis on your request card, that this is a catheterized urine, you will see a growth less than 10 to the power 5 and say it is not significant. But with the diagnosis or with the history you have about the patient, you can go ahead. For Candida, any count you see is reported, right? Because it is important when it comes to people with diabetes and immunosuppressed people. S. typhi, colonies less than 10 to the power 5 are also very significant. Salmonella typhi infects the stomach, of course, the blood. So it shows usually it is from ascending UTI. Okay, so any amount is significant. Then all symptomatic UTIs should be treated once there's bacteria in the urine and once the person came with signs and symptoms, we should treat them. Now, When the person took, if the person took antibiotics recent to the testing, you can get a false negative result. So if you have diagnosis that the patient was on then you are getting a result which is negative and the patient is showing all the signs, you can go ahead and repeat after the medication. Also, urine samples that are left on the bench for more than 2 hours at room temperature, there is bacterial growth. E. coli generation rate. E. coli in 30 minutes time, it multiplies to 2. So as you leave it for long, it keeps on multiplying. It can get a false positive result. Even contaminant in there can also multiply and give you a false positive result. It is paramount or very important to know that you need to treat UTI, positive urine culture, by comparing it with clinical symptoms. It is not every positive urine culture that shows that the person has an infection. And this leads me to talk about what we call asymptomatic bacteriuria, ABU. So in asymptomatic bacteriuria, the person is healthy, has no signs of symptoms of urinary tract infection, like what we discussed at the top, has no signs, but we have cultured bacteria of 10 to the power 5, which is significant in the urine. And this is when it is even done on 2 consecutive times. But bear in mind that it says irrespective of pyuria. So asymptomatic bacteria is when 1, the person is healthy, the person may have or may not have pyuria. The person will have a significant growth in the urine, and then the culture is positive. But this is not a urinary tract infection. And in these cases, treatment is not recommended. Treatment is not recommended. It is common in some people, in some healthy females, you can find it there, in men and women with genital urinary abnormality. In fact, they have similar indications like UTI. Okay, but you have to make sure that the person is showing the signs and symptoms. All right. So in pregnant women, even though ABU, asymptomatic bacteria, should not be treated, in pregnant women, there could be the likely risk of development of UTI, and so we have to treat. And then if the person has all these bacteria in the system, but is going to have an invasive procedure, then there should be treatment of that asymptomatic bacteria. Aside that, asymptomatic bacteria treatment is not recommended. In children, usually they compare other imaging results to treat. So we may say this is not too important to us as a laboratorian, but we are giving out the reports. So we should understand some of these things so that when the doctors come to us, we can talk science. All right. With that said, we can take a stretch as we prepare ourselves for culture of aspirates. Let me just have a minute to get a glass of water because I changed my position. All right, I'm back. Thank you. Okay, so now we are talking about aspirates and exudates, and we get them in different forms in the lab. We can get pleural effusion, which is fluid that collects around the layers of the lungs. Pericardial effusion, fluids that build around the cavity, the space around the heart. Aseptic fluid, that's from the peritoneum. We can get aspirates from knee joints, even from the eye, and from boils, which we usually call pus. Now, what we have to bear in mind is that All these aspirates are coming from presumably sterile sites. So the heart and around the heart is a sterile site. The lungs and around the lungs is a sterile site. The peritoneal area is a sterile site. Inside the eye is a sterile site. In the joints is a sterile site. The ball is a projection of the skin. Now, inside the skin is a sterile site. So it means that your sample is coming from a place where you shouldn't expect to see any bacteria. And so if you see any bacteria, you should be alarmed. Your lights should come on. And see what is happening here. The rad agar, chocolate agar, maconke, sabrodextrose agar. You need your sensitivity agar, your identification media. You need your antibiotics, your plasma, your saline, your gram stains. You need your slides and cover slips, beakers. You need your microscope, your incubator. Similarly, you check your sample, make sure the sample is for the client. The same name on the container is the same name on the specimen, have their specimen rejection criteria. But some of the specimens are liquid gold. Just imagine CSF, how it is taken, being taken during surgery. And so if there is any eye and troubleshoot, find out what is happening. You can even go ahead and start processing because of time and take notes that there's a mismatch in name, and then later you sort it out. Even urine that we think is easily avoided. People with renal cases, renal conditions may have difficulty in passing urine. Is my line breaking, please? Oh dear.
Oh, it's okay. Once in a while, I think it's not that bad. So maybe you stick to where you are now.
Okay, thank you very much. Yeah. So your samples, once you sort all those things out, you give them a laboratory accession number, and then you process it immediately. For these samples, we do not recommend you refrigerate because they can contain some bacteria that are killed when you refrigerate. So you process it immediately. So for our aspirates, for our pleural effusions, for our pass, for our excessive fluid, you describe the macroscopic appearance. You inoculate onto blood agar, chocolate agar, maconke agar, and then when there's the need for fungal, you add your sabrodextrose agar. And then you incubate, but the CA goes to 5% CO2 jar. Very important for all these aspirates, you have to perform gram stain. And when requested, or when the diagnosis is suggestive, you perform your Z10 or Indian ink stain. Please, gram stain is very important for these tests, these samples. All right. So the candle jar, I just brought this in because I know a lot of us do things wrong. This is to give us, this is not anaerobic. This is microaerophilic, and it is to reduce the amount of oxygen in the jar. So you arrange your plates or your tubes in there, you put in your candle, and you close the lid. The candle will burn as long as there's oxygen in there. So it will burn till the oxygen level is very low, that it will go off. And then you have some CO2 in there for the bacteria to grow. Now, aspirates or these fluid samples, I brought this here because I want us to know that some bacteria have different oxygen requirements. Some are obligate aerobes. They need oxygen to grow. Some are killed in the presence of oxygen. Oxygen is toxic to them. Some need a little, some are facultative, anything goes. So your aspirate is coming from some deep-seated place be in the human body. And most of those places are anaerobic or reduced oxygen. And so when you bring the sample to the lab and you treat it direct to that plate, which is going to be incubated aerobically, you may lose some of these bacteria that requires some of these oxygen requirements. And so for aspirates, effusions, pass, we are supposed to enrich the process. So you put a few mils of the sample into a thioglycolate broth, and then you incubate overnight. You incubate overnight together with your plates. So here, when you are streaking, you can use a full plate or half plate. This method suffices in aspirates. Okay, so day 2, you come in to read your plates. You are reading your chocolate agar, blood agar, McConkey agar, and comparing them. What is here that is not here? What is not here and what is here? So this together will help you decide. Then whatever you have cultured, you go ahead and do your gram stain to inform you as to which path to throw for your identification, like I said at first. And then you do your sensitivity when appropriate. You do your sensitivity where appropriate. Now, on this day 2, you pick up your subcultured broth if there is no growth particularly, and then seed it onto another BA, CA McConkey, and incubate. And then you come and continue with this process. I don't know if I am clear here. Now, on the 3rd day, you read your AST, you read your biochemical tests, and then you validate and send out your reports. Now, we have to know that all samples taken across the skin barrier have the tendency of being contaminated by skin flora. So for eye swabs, wound swabs, aspirates, CSF, all those samples, once you breach the skin to get your sample, there could be skin flora contaminating it. So in as much as we have said that these samples are coming from sterile sites, and so whatever you see should be of consent to you, you have to rule out skin flora. So if you come the following day and you've seen beautiful growth on your BA, beautiful growth on your CA, it didn't grow on your McConkey. Okay, you did your gram, you saw gram-positive cocci in clusters. Okay, it's staphylococcus. Then you did your coagulase, it is negative. You know you have coagulase negative stuff. You shouldn't be too alarmed and go ahead and do identification. This could be a contaminant from the skin. Okay, so always rule out skin contaminants. Aside that, you follow all isolates with the exception of skin contaminants. And then you perform identification and ASD according to the CLSI guidelines. Then with that, your result is generated. You report the gram reaction, the identification, or that's the name of the organism, and then the drugs that you used, those that were sensitive, those that were resistant, you put them all in the reports and send to the clinician. Now, we have to be mindful that because cultures usually take more than 2 days, you should always report critical values to the clinician. Let's say on the first day you did your gram and you saw gram-positive bacilli with a central spore. You are getting Clostridium. And you should know that Clostridium, some of the organisms cannot be cultured. Or let's say a sample from the heart. Your first day you did it and you saw gram-negative rods all over. You can send this report to the physician as a preliminary report whilst awaiting the other 2 days. Because with that information, they can start empiric treatments. My personal experience, and I don't know if the colleagues that I were on duty with are on this stream and they will attest. So usually we think it is just plating the aspirates and then going ahead. But this particular day, I was very intentional about performing the Gamls smear. It was from a peritoneum, ascetic fluid. And then when I did the Gamls smear, I was surprised to see gram-negative intracellular diplococci, GNID. I was like, what is happening? GNID, I'm expecting to see from urethral samples, but this is from the peritoneum. Then I went on to read more about the patient. Apparently, the patient had a hysterectomy. And then after that, the stomach kept on bloating and bloating and bloating. So they brought an aspirate into the lab and then for culture. So this tells us that this lady, before she went for the hysterectomy, had gonorrhea and it was not identified. And after the surgery, it has gone ahead up into her system to cause further infection. Now, this same case, it will surprise you that the gonorrhea failed to grow on our chocolate agar. Like I'm saying, gonorrhea is fastidious. Neisseria gonorrhea is fastidious. So when we are suspecting it in the lab, we let the patient bring the sample, we take the sample direct from the patient and plate. So this one, looking at the transit time for the aspirates, when the doctor took the sample, the patient will go and look for money to come and pay, all those things. That waiting time might have caused the bacteria, the gonorrhea, to die in the specimen. So, but for the gram that I did, we would have missed this very important pathogen. So like I'm saying, gram is very important. And whatever you see in your gram smear from aspirates, from pus, from effusions, you can forward them to the clinician as preliminary reports whilst awaiting for the real culture results. Now, I said that some of these specimens are collected from areas in the body where there's very little oxygen present. And so there is a need for aerobic incubation. Okay, so there's the aerobic, the aerobic jar, or we have aerobic pack and even aerobic media that can be used in this anaerobic incubation. But look at this funny thing. We move on. This is a gas gangrene caused by C. Clostridium perfringens. And this bacteria is anaerobic. It will not grow in the presence of oxygen. Oxygen is toxic to a system. Okay. And so if the physician takes the sample, puts it in a normal aspirate container, I failed to bring a container for aspirates. Puts it in a normal sterile container for aspirates. The patient's relative brings it all the way to the lab. The pathogen in there, because it is anaerobic, will die because of the oxygen around ourselves, because of the container that we have sent out. So they are anaerobic containers. This one is my case. The air has been sucked out, so there's vacuum in, and the cap is this penicillin container. So there is virtually no air in there, no oxygen in there. So when you take your sample, this is the ideal container for anaerobic samples. But how many labs? I have not even using this in all my 18 or so years of practice. Space or Strauss media, which can also be used as anaerobic transport. So from the first place, our samples are collected wrongly. Our samples are put in the wrong. You may not be able to culture it. That is where the perfringe is. You may not be able to culture it, but your gram will show gram-positive rod with a terminal spore. For actinomycetes, you will not culture it, but your gram will show gram-positive branching filamentous rods. So ladies and gentlemen who are practicing microbiology in various institutions all across this country, please let us take our gram stain very serious for our aspirates. All right. So when working on these samples, we have to think of quality control. Every stage of the test, you control your media, you control your coagulase test, you control your oxidase, all the gram stain. Every stage you have to control and document them in your laboratory logbooks. So ideally, when you are working on some of these samples, because it takes a long time, sometimes 3 days, 4 days, sometimes even 5 days, you have to repeat some tests for the results to come out. Although some organisms may be killed in the fridge, it is prudent not to discard it right after plating. You have to keep them in the refrigerator until your result is confidently out and dispatched before you can go ahead and discard them. You can also stock your isolates for use. And then for your waste, it has to be segregated. These samples shouldn't just be poured down the drain. Okay. So we are almost ending. For safety, for both urine culture and for our aspirates, these may contain infectious microbes, bacteria, viruses, parasites, fungi. And so we need to put on appropriate PPEs. We need to wear our gloves when working on these samples. We need to put on our goggles, put on our nose mask or face masks when working on these samples. Also, when doing culture processes, we are exposed to fire. So there could be fire hazard. The lab is not for the woman who sells the food across the street so that she can come in and bring your food. It is prohibited to unauthorized people. There can be glass injury, so we should take note of that. And some of the chemicals we use for our tests can be corrosive, so we have to take note of that. Now, today, my closing address will be a form of advice. Over the years of working in microbiology lab, I have realized that sometimes physicians come in frustrated, if even I may say angry, because the results has kept too long. They are seeing the patient and see what the patient goes through. And so they come and they're like, I need the reports, I need this, I need that. And then the lab scientist will bore. Most of us will do that. We'll be like, we'll tell him, this is out of bounds, don't enter the lab. So he'll be outside the lab, angry, and you'll be inside the lab doing anything. But over these years, I have come to learn that the Bible even says that a gentle answer, something, something. So it is always prudent to call the physician, explain, because they did only 1 year of med lab. Explain your part, your bit, whatever is happening, why the result is keeping long. Even if necessary, if you want to even show plates for them to understand. And usually when we do that, they calm down, they understand what is happening, they are able to relate with us. They don't go out with a bad name that the labs are this, the scientists are this, they are that. And as we are fighting, it is the poor patient who is suffering. So please, let us put our ego aside when it comes to the patients. and meet the clinician, because we are a team. Discuss the patient in the patient's best interest. Sometimes in the lab, is my internet going off?
You are okay, please.
Okay. Sometimes in the lab, I have been in the lab several times. A physician will come and he says, I want sensitivity pattern for bacillus contaminants. I want sensitivity pattern for staph epidermidis. And they are like, I need it and I need it. And so you see the person that you say 1, 2, 3, 4, 5. 1, 2, 3, 4. Because of this, we don't give out drugs for this. You even educate this bacillus contaminant in the blood culture. It's as a result of poor sample collection from the ward. You go ahead and educate. And in so doing, the patient is helped by our agreement. So I close by saying, let us try to jojo with our team, our other clinician team, so that the patient will benefit. Thank you very much. One of my partners. Okay. All right. Dr. Kwashi, thank you very much. Over to you. I will come back briefly.
Thank you. So I will just come up with one question, then I'll hand over to the PRO. He does better. He does better questioning than I do. So how do you relate? I know some labs take sample for both urinalysis using the dipstick method and the microscopy, and for culture. How do you relate the two?
Dr. Kwashi, if I get you, you were asking how we relate the urine analysis result to the urine culture result, right? Dr. Kwashi, is that your question, please? Hello, can I be heard, please?
Yes, you can be heard.
Is that what he asked?
But maybe Solo will come back. Possibly, I don't know his drop off, but we have 2 hands, so maybe Doc.
I think I'm back now.
Okay.
Okay.
I'm saying that in some labs, I know you have labs that does urine array separately from culture in 2 different labs. How do you relate the two so that you are sure that you are giving results that aligns with the clinical symptoms and also doesn't disgrace your lab?
Okay, so I'll use my lab as an example because we run culture and array in 2 different labs. So usually when you are entering the results, so the array lab does their tests and enters in the system. So when you are entering the results, you always compare to what has been done in the system. So if you are entering a culture result and there's an array result already entered in there, you compare it and see that everything is aligning. Okay.
So, okay. All right. So I'll hand over to the PRO. PRO, you can continue.
Okay. Thank you very much, Dr. Okay, and thanks, GS. So I think what we do is I have seen a couple of hands raised. We will take the ones that have been typed first, then I'll come to my colleagues who have their hands raised up. I can see Beatrice Azavu, Isaac Etiwa, Dr. Francis Antwi, and Daron. So please hold on a bit. I will call you to come up with your questions. But in the meantime, those that have been typed out, if we can quickly run through some of them. So the first question to look at from one of our colleagues, that is Enoch E. Quansen. To prevent pressure on lab results, I think with that, the lab should prepare turnaround time for each individual test and paste at the consulting rooms and wards. I think there's more of a suggestion to see how best you want to deal with pressure on your laboratory. So if they know it is expected, then once the time is not up, maybe somebody may not come worrying you. Then the other one is from Jupiter A. Kodo. On the TB bench, let's not accept the green top container, which is not screw cap, because we will end up infecting ourselves with this kind of container. I think Jupiter is also kind of sounding a caution on the use of the containers for TB, the sputum collection. Yeah, probably just a caution across. So maybe, Doc, this is coming for you. What is the fastest way of doing urine culture in time of emergency when the patient cannot wait 2 to 3 days for the results? From Michael Shebra.
Okay, so when the patient cannot wait for 2 to 3 days for the results, you let your urine analysis prompt you. So what is the analysis saying? Do you have the dipstick? Do you have white cells, leukocytes reacting? Do you have nitrites reacting? Are you seeing lots of past cells in there? All right. Are you seeing protein? Because some of these organisms like crystals, even crystals, triple phosphate crystals, is indicative of proteus species. Are you seeing all those things? They could be indicators. But and culture and do sensitivity plates on sensitivity strips. But then you don't know whether you have a single or multiple growth. So there's no two ways about it. You either wait on your analysis and then wait for the culture. That is what I have to say. Thank you.
Okay, thank you. So this is coming from Pabam Kwaku Bento. Please, how do I know that a growth is a contaminant on a cultured urine? And also, what is the standard way of reporting HVSRE gram stain? So maybe the contaminant, how do you identify contaminant on a growth for urine culture?
Thank you. On the Dr. Lidis, can I go ahead?
Yeah, please go ahead. Hello?
Hello? Yes.
Yeah, can you hear me? Dr. Can you hear me?
It went off a bit. I was going to answer.
Please go ahead.
All right. So for identifying the contaminants on the culture loop touched and where it spread through, that is where your isolates should grow. A contaminant will usually grow away from your inoculum or where you did your
Hello, Doc. Hello.
Yes, Dr. Edudesi.
Yeah, please. There was a break. So when you started talking about how to identify the contaminant, so if you can take it again.
All right. So to identify a contaminant on your culture media, if you do your streaking where your lines passed, if there's any growth outside where you put your sample, those growth outside it are contaminants. So anything outside your pool and your streak on your culture plates, you term as contaminants.
That's very good. So if it's not something you introduced, then it's one key thing to pick up as a contaminant. But then if it's something also coming with the sample, then you are likely to even find them still in your streaking. But you may want to check what sample are you dealing with, and are you likely to find this organism as a pathogen or as a commensal? So I think it's good guide you have given for us to look out for the possible contaminant. With urine, I think it's quite difficult, but it comes with experience, especially when you are dealing with more than one organism growing.
Exactly.
So, Doc, can you also help with standard way of HVS, RE, gram stain? I know it might be exhaustive, but if you can give a brief overview of how do you advise that we report on HVS routine examination.
Okay,
Gram
so
stain.
For the gram stain, you are looking for particularly in HVS, you are looking for your Neisseria, gonorrhea, GNID in your HVS. So you report your white cells, you report the epithelial cells, you report Candida if they are present. You can even go in and look for Trichomonas vaginalis, Gardnerella vaginalis as well by looking out for clue cell. Lots. So, and this is coming up, I think it is on one of the days, I think the last day. So if you can hold on so that you can really exhaust that.
That's good. I think it will be good. And Doc, I reiterate that some of you with your experience, you need to help the professional body in putting some guidelines together, say for reporting on HVS, RE, say for gram reporting, culture reporting, so that the professional body can publish that, which becomes kind of standards within Ghana that can be used for such purposes. We have that power that once we set it as guidelines, it's expected that should become the standard way of reporting. So we will encourage some of you as resource people to come up with some of these guidelines that I know can live on forever and ever. All right, so I don't know, Justice Donko is putting up, let me see, with exudates or parasite, is it important to do grams before plating and after bacterial growth? That is with exudates. So Justice Donko, I think, has a couple of questions. Justice Donko says, with exudates or aspirate, is it important to do gram before plating and after bacterial growth?
Yes, my dear, it is important to do gram, but you do it after plating. The reason is we have the thought that the method of collecting the sample from the tube to your slide and coming back to the tube to the slide may end up introducing contaminants into the sample. So we recommend that you plate your culture out before you go in and take your sample to do your gram. Now, after culturing, whatever has grown, you don't know what has grown unless you have worked with so many years experience. Even with that, some of the bacteria are able to outwit. So after culturing, whatever you have grown, you need to pick the isolates and gram it out to see whether it is gram positive, gram negative, to aid you in how you go about your identification. Thank you.
Okay, thank you very much. So the second one is with the enrichment of the samples, if you don't have thioglycolate, can you use peptone water or BHI?
You can use brain heart infusion. rather.
Okay. So the third one is the CLSI guidelines for AST are updated yearly. But to get them, you will have to buy online. Is there a way Gamls can procure and share with labs who do microbiology? Now, I think there is more to Gamls, and it comes back to some of the suggestions that we have had the idea of putting together guidelines that will be published and accepted as standards for practice of medical laboratory science in Ghana. And I think that when that materializes, that means we can get some of these international guidelines, review them alongside with research and practice. Then we come up with standards that will be suitable for our practice in Ghana. So thanks for bringing that up. I believe leadership will take it up and fall on expertise like Dr. Okan and see how these things are brought up. It's very necessary so that when there are legal issues and stuff, these are the standards I believe the courts will want to fall on in making their decisions if we did what is expected and how it's supposed to be done. So Justice, I think this is well noted, and we will get back to that vision and work on it. So please, I want to know how Candida species relate to diabetes as seen in the presentation. So this is coming from Francis Gla. Dr. Okan, please, are you around?
Yes, I am here.
Yeah, so somebody wants to know how Candida species relate to diabetes as seen in the presentation. I'm not sure, but probably in diabetes, do you expect when you are doing urine, Candida species to be picked out?
So Candida is mostly seen in people with immunosuppression and in diabetic cases. I don't really get the question how to pick it up. I don't get the question, please.
Yeah, Francis Gla, I will be happy if you could rephrase and clarify the question if it's not clear. Yeah, because I know Candida in immunosuppressive people, yes, you are likely to, or you should look out for it. Or when you see it, you may want to get a history, the clinical history of the people, and know how to report it. And possibly you may want to repeat the sampling. So please come back again so that Doc can be clear on the question. So Mansu Dennis Komla is asking whether it's a good practice to use a single urine sample for RE as well as culture and sensitivity.
Yeah, Dennis, you can do that only if you are culturing the urine first before you go ahead and do the RE. Thank you.
All right. So I think I'll take this and get back to those with hands raised. And this is coming from the person, the name is Laboratory. Unfortunately, the proper name is not there. So, Doc, since catheter are not daily changed, is it advisable to collect catheterized urine for culture after 24 hours of wearing, though urine was passed freshly?
I don't really get the question, but
I think it's a guide on how do we have to go about it if we have to use catheterized urine for culture.
Okay, so let me go back to this slide to make it more. So for catheterized urine, like I was saying, you don't pick the urine from the back. You don't pick the urine from the tubing. And even ideally for catheter that has been in place for 5 to 9 days, you don't want to pick a sample from it because there may be biofilm formation of bacteria in there. So this is not taken by the labs, but we can direct the nurses on taking that. What you do is you drain the urine from the tubes, drain it all the way out into the bag, and then clamp the tube and give yourself a few minutes for the catheter to fill. Just at the port, there's a catheter port, urine is aspirated from that place. So we don't take urine. So when you get urine, it says catheterized urine, you want to ask your nurse or your physician, how was this urine collected? If the process doesn't fit to what we have just discussed, you educate them for the correct preparation. In the same vein, when the catheter is worn fresh for the first time, that one you can also use it for culture. Once the catheter is passed through, a few mils of urine is allowed to come out, and then some is collected for culture. Thank you, Doc.
All right. So, Albert Afisa, I think your question was still about using urinary and urine CS at the same bench. But I think this had been mentioned just to rule out error, whether it's a best practice to do both on the same bench. So I think, Doug, how do you advise collecting
is it on the same bench?
Yeah, on the same bench.
The same.
So would you advise doing urine CSRE on the same bench?
No, I will not advise on the same bench because of centrifugation. So you know, centrifuge releases aerosols, and some of these can move into our culture plates and contaminate.
Thank you. So a bit dicey. What do you advise if a woman in the period of the month needs to do a urine RE and culture? Potential of getting
a room for examination. A room for.
Sorry.
I advise 2 separate rooms. A room for culture and a room for, but if not, we can allow, yes.
Okay, thank you very much. That's well noted. But the other point is a woman in the period of the month needs to do a culture and sensitivity for urine. Would you advise that is done with a bloody urine? Somebody is asking that question, laboratory, yeah.
Culture?
For culture and sensitivity for a woman in
with
the
bloody
period
urine.
of the month. Yeah, bloody urine, yeah.
Oh, it can be done. It can be done.
So far as it's midstream.
Exactly, it can be done.
All right. Thank you very much. So I think standard way of reporting WBC past cells in urine RE. I think let me get to Doc, would you want to take that? Do you have a standardized way of reporting past cells in urine RE?
There's a range. I think 1 to 5 is normal, 5 to 6 is trace, 6 to 10, 1 plus, 10 to, there's a range. I don't have them offhand, but there's a standard way of grading urine, white blood cells in urinary.
Oh, so I think Collins Asilevi is asking claims. There are claims that some herbs and plants have antibacterial and antifungal effects. If an MLS wants to verify such claims, how would you suggest we go about it in the interim in our laboratory?
Okay, so you want to be running the sensitivity of your herbal products alongside the routine antibiotics. Is that what I get?
That's what seems to be the case.
Okay, so the difficult bit with most of these herbal formulations is not knowing the, like, if I take 1 ml, what is the component? But if you want to go ahead, you seed or you inoculate your molar-hinting plates, but before then you make wells. You aseptically make wells on the plates after seeding, and then you put a few volume of the herbal medicine onto the plates and incubate. So like I was saying, you don't know how much 1 ml, what 1 ml will contain. Like when you take your antibiotics, maybe vancomycin, we have 30 micrograms of active ingredients in there. You can know that for this drug, amoxicillin, we have 30 micrograms of active ingredients in there. But if you take 1 ml, 1 microliter of your herbal drug into the well, we can't tell what is the active components or what is being spread out onto the media. Also, you can do the broth form. You can do serial dilutions of your herbal products. I believe this liquid, and then you add standard mils of inoculated bacteria into the broth, incubate, and you look out for turbidity, and then you can work with that. But when it comes to the herbal side, a lot goes into, since we don't know the active, like we can't measure what is in a ml of the herbal components. Thank you.
All right. Thank you very much, Doc. And
Piero,
so,
if I can contribute.
Okay, yes, go on.
So I think that for these herbal extracts, you have to do a lot more research to even look at how to extract the phytochemical agents that can inhibit the bacteria. And it needs a lot of research. Sometimes leak water may not be the agent useful to get the phytochemical agent. You may have to use other chemicals, and you may have to find out what is the effect of these chemicals you are using for the extractions on the product. And it is important that you have to go through some level of scientific analysis to identify the exact product, because if you are using the crude product, you don't know what is actually causing the inhibition. And so it may need a whole lot of research than just using the product. Thank you.
All right. Thank you very much, Gia. So our colleague Collins Asilevi, and probably as many may be thinking, as much as we can do it, it's important you want to find out when you are done, whom are you going to communicate your results to? Is your results going to be accepted by the claims you are going to make? Your preparation of the crude herb, was it done in accordance with GMP, the good manufacturing practices? Are you just going to pound it and squeeze so that you now have your crude extract? Are you going to talk about sterility of your crude extract? If you are able to, if you isolate something, are you going to say that it's rather because the bacteria is resistant to the herb, or you had contamination in your herb preparation? So because of all these things, you want to go through some ethical processes. The FDA, by the laws of Ghana, will have to take care of these by the Public Health Act, to take care of all the clinical trials, because this one, now you move into the arena of clinical trial. So let's see how best we separate our health practice as professionals from what research is. So that when your result is communicated, it would have been verified, it would have been validated according to standard practice, and everybody can now go ahead and say that, oh, the Achampon herb, when you take this amount and prepare, dissolve in ethanol, methanol, or whatever, this volume when used can prevent or inhibit the growth of that. Then now you may be suggesting whether people can take it or not against chloramphenicol, against Cipro, against all the amoxicillins that we know on the market. So yes, you can do it as Doc has said, but make sure you go through the rigorous processes. And it might not be in the laboratory, but probably a different lab set up for that purpose. So you have to watch it so that you don't compromise on your professional practice for patient care and also that of clinical research. That's what I would just want to add to it. All right. So, Darren, Angel, I can still see the hands. We will come to you, but let me just exhaust these questions quickly. Kodo Brilliant is having a question on Vibrio cholera and the parahemolyticus on Maconche agar. Can you isolate these organisms on Maconche aside the TCBS?
All right, so for the TCBS Vibrio, I am sure about that. But the other organism you mentioned, I cannot tell. For TCBS, for Vibrio on Maconche, I am not sure about that. Vibrio has to be cultured on TCBS.
All right. So thank you very much. And I think these ones, if we are okay, it's better we work with the known media, and possibly you can improvise for the one you are suggesting when you have the known one, so that if you are getting the growth compared to the known ones, then you can be making a case to improvise when you don't have the TCBS. Yeah. So the standard way of reporting urine RE, is it in absolute values or ranges? Please do both. Have your range, have your absolute figures as you are picking on the field or on the wet mount. So I think I want to go to the hands raised and come back to the questions at a later time. So please, Darren Davis, can you unmute and ask your question or contribution? Darren? GS, did you make the settings that people cannot unmute?
Yes, let me correct that.
Please, yeah, take it off. So Darren, please unmute.
Okay, thank you, Dr. Edujesi. So I have two quick up. One will be a suggestion, one will be a question. So my suggestion, this will be in relation to the pre-analytical phase of sample collection that especially that comes from the ward that we may not be there to ensure that the appropriate sample is collected. I think with the practice of laboratory quality management system, the handbook is one of the key tools that as scientists, we need to train the clinicians and then the nurses and the disease control officers who help in taking off samples at the ward for us. Aside the training and physically giving them the handbook, one suggestion or recommendation that I want to make is we should tease out the salient points of the handbook and then ensure that it is pasted at vantage points where any clinician or any nurse who easily make a quick reference to in situations where they are in doubt or they need help. Then my question, it's so antimicrobial resistance is on the rise, and on the part of the lab, we are doing our best, even though from day one we realize that across the country we don't have a lot of labs doing the culture. I stand to be corrected, but then the laboratory results are not something that it's mandatory for the doctors to abide by or go with it. In the event where they also have, the clinical judgment from their part. But I want to find out from Dr. Okan as to whether per her practice, is there a way that the lab and the pharmacies could ensure or could have access and see that based on the lab results with respect to the susceptibility pattern of organisms, what are the antibiotics that the doctors prescribe? Are they in conformity to what the lab results come out, or they are different?
Okay, Dr. Can you take
Davis,
it?
I think you are breaking. Is it my side?
Whoa.
Hello?
Yes. You couldn't hear Daron?
I couldn't get the full question.
Okay,
So
Daron, can you repeat, or I can yeah, Daron, repeat,
yes,
please.
yeah. So my question is that it's more often than not, the usage of the laboratory results is at the discretion of the clinician. Now, antimicrobial resistance is on the rise. So I want to find out that per her experience and practice, is there a way where there will be some collaboration between the lab as far as the AST resource is concerned, in relation that is a doctor going in accordance with the result that had come from the lab there, and what role or what advice would the pharmacy play in ensuring that the right, drugs or antibiotics is being prescribed to the patient?
Okay. Thank you for your question. For the lab, what we do is we have our own form of antibiotic stewardship, like the CLSI guidelines. You know the drugs to give for each condition, the first line, second line, third line to give. And so it is ideal to report these drugs. That is why I said the multi-disc was not the best, because it comes with everything. And some labs may report everything to a physician who may not be privy to which drugs to use. So for my institution, for instance, and I think other institutions to take it up, after everything, after all the culture, after all the ASTs, we don't give out all the drugs. We give out the pertinent ones, the first, second, third classes that we think, based on the diagnosis given, we should let them go out. So those are the drugs that we give out. We give out both the sensitive and then the resistant ones. As to whether a doctor will use it for treatment, we cannot tell. But what we also advocate is to have regular meetings with the physicians. So maybe you go to your surgical department and present to them, this is what we have seen. This is the trend we have seen in E. coli resistance from your department. Samples that came from Ben's unit. This is what we are seeing. And these will help inform their treatment. For the pharmacists, they also have a role to play, especially when it comes to the load. So several times I have seen pharmacists advise physicians on, advise physicians on the load of, or the dose of antibiotics to give. Yes, thank you.
All right, thank you very much. But Daron, what I want to mention and add is that it's not about whether something is mandating somebody to use laboratory results or request and that. If you have witnessed audits, mortality reviews, and all reviews in hospitals, you realize that there is nothing mandatory. If there are mortalities and you are looking for the causes, that is where somebody goes through the guidelines to see whether you stuck to the SOPs or you use your own discretion. You have discretion to use, but it must be in accordance with standards. So check the standard treatment guidelines in Ghana. There are things you have to do to make a decision on malaria, to make a decision on sepsis and all that. So nobody is a man of his own. That's why the lab exists. If the capacity is not there, there is a process for referral. Make sure the person gets those conclusive decisions. But when it comes to your own discretion and there are issues, that's where you realize that you needed to use what was right and per the guidelines. So it's not about mandatory or non-mandatory, but all guidelines are supposed to be adhered to. And for that matter, when it comes to the lab, they also want to find out whether you did what was right according to the guidelines, but not using your own discretions. So yes, once in a while, make sure your antibiogram is published, is profiled, then we know what can inform them, even though they want to do some blind treatment before your results is ready. Thank you. So the next I want to take from Beatrice Azavu. Beatrice, if you can unmute to ask your question or contribution.
Okay. Thank you very much for the I have myself questions. And my first question has to do with WBC counting, where you have a parcel for culture, whether it should be done if it's for if you receive a pass specimen, then personally working on the bench, I've had few issues working on the coagulase test. The coagulase test using the control. Sometimes there is reporting becomes a bit difficult. So I don't know if you can share some of your experiences with me. And
can you be specific with the difficulty, if possible?
The coagulase test, the 24 hours.
The coagulase test, yeah. Yeah, Beatrice.
Yeah, sometimes, I don't know, you tend to have, maybe if you have the control, you set a control, and then you set a negative control, you have the patient result, then in 24 hours, you realize that, I don't know whether it's contaminant from my plasma. You realize the negative control is also showing coagulation. So I don't know if...
Right. So Doc will share light on that.
Yes, so I want to know.
Is that all?
And then, no, please. Then in cases where you see pseudo-hyphae, and then you slice cells together in an RA report, please, how do we report that? And then with regards to the urine RA and then urine CS in females, when we are reporting, sometimes you see that with the females, the contamination with bacteria, you see that sometimes the urine has no significant parcels and all that, but then there are a lot of parcels and there are a lot of bacteria. So how do we, with females, should we, what's the recommendation? Because sometimes I feel that it comes to the females because of contamination. When you use the she was talking about using the first the same specimen of
Wow, Beatrice, you seem to be breaking up. So Doc, maybe can you take the first two, and maybe when Beatrice
I think that it's a better option. So I don't know if she can show more light on that. And then my final...
You were breaking. So let's get a third one right. The third one, your worry is if you tend to have a lot of bacteria in the urine from women
when you have
cells, how do you go by it? Is that a question?
Yes. And
right,
then
that's
she was talking about it's here. It's where there are a lot of normal flora. What about how do we do that? I see that it will be more difficult to report.
Please, can you repeat the last question with the normal flora issue? Can you repeat it?
That's what I
Yeah, Beatrice, I wish you can put the last question in the chat, please. Put the last question in the chat whilst Doc answers.
Then when it
So, Doc, can you please help us?
I think she should also add the first. She was asking something about parcels, WBC. So she should also add that in the chat. So I'll start with the coagulates. First, you have to make sure the tubes you used have been autoclaved, okay? Because you can have some bacteria in there giving you a false positive or gelling of your media. You should also check your plasma, like we are saying. All right. Then you read your results in 4 hours. Eunice, read your results in 4 hours. If it is negative, then you can keep it to the 24 hours. So if you're not doing that, kindly take note of that. So for the yeast-like cells with a hyphae, your request form should have provision for yeast-like cells with hyphae. If you don't have that, you can put it in your comments. I don't know if your urine analysis form has a place for comments so that you can put miscellaneous items there. So you can report that in your comments. Then contamination. Contamination. Please, can you come again with your first, fourth, and fifth question?
So I think the first two you are done. The other one was on having bacteria in the urine from women, but you don't have past cells. How do you juxtapose that with a possible normal flora coming from the woman urinary tract?
I'll ask you how long you've kept the urine. One, even how was the urine collected? Was it a midstream urine? All those things should be clarified. It is possible to have a lot of bacteria in the urine without white cells if these conditions are in place. The urine is standing for a long time. It's a poor urine, maybe from a catheter bag, or the sample was not collected properly. It wasn't a midstream urine. So kindly find out all these things. It will help
and possibly ask for recollection.
Exactly.
Yeah, thank you. So Isaac Etiwa, please can you take up your question?
Okay, sir. Thank you very much for the opportunity. Thank you very much, Dr. Okai. First of all, I would like to say something small. Someone asked a question pertaining to how you could probably give a result faster when you are doing CS. Per yesterday's studies, I realized that probably the chromogenic media can really help for that part or preliminary results for the doctor to start probably treatment before sensitivity will be done. So I think that can also be one of the things that can help to fasten your results when it comes to urine CS. Now, secondly, my question actually is that you were talking about the anaerobic or setting up the anaerobic conditions to actually cultivate to grow the anaerobic organisms. In a case where I don't have a canister, which I have done before, I actually used 1,000 ml of beaker, which my petri dish can actually enter. Then I drew a circle on my bench.
Hello, Isaac.
Hello? Yeah.
Please get closer to your system because it's a bit hazy at the background. You are not too clear, and especially our colleagues are also listening in on YouTube. So if you can retake it, but please get closer to the device.
Please, can you hear me now? Is it okay?
Yes. Are you using a headset?
Yes, please.
You seem to have some echo that I wish you could avoid that, but you go ahead if that's the best you could do.
Please, can you hear me now?
You are clearer now.
Good. So I was saying that pertaining to the question that our other colleague asked with the urine CS, which should be, I mean,
Perfect.
Probably the doctor needs the results faster. I was thinking that yesterday we treated something related to the culture media or the culture agar, where we came across the chromogenic media, which I think that can also help since it actually gives a coloration to the organisms. Coloration to the organisms or the organism that is being expected, which can also fasten the results for the urine CS when it comes to that question. That is my suggestion, though I stand to be corrected. And secondly, the question that I wanted to ask is, Dr. Okain spoke about the fact that we can set or we can use the canister to generate anaerobic conditions for culturing. Now, where we don't have a canister, which I have practiced before, I used a beaker with a wider mouth, about 1,000 mils, I guess. And I drew a circle with a beaker, use a candle to seal it, and use about 2 or 3 candles to give a maximum, probably, carbon dioxide in the system. Is that, or the candle I used, which I think is going to give a maximum carbon dioxide in the system or create enough anaerobic condition, is it conducive or is it okay to achieve that? And secondly, the method which I used, is it like okay? Because I'm thinking because I don't have a canister, I had to use that method for the anaerobic condition. Thank you.
Okay, thank you, Isaac. So let me correct you by saying that the canister does not give us anaerobic condition. The canister rather gives a microaerophilic condition. And if you don't have a canister, you can get any container that has a tight lid. It has a lid. So the beaker you used, did you have a cover for it? If you didn't have a cover, then I beg to say nothing was done. So you can go for a container, any container with a lid, and it should be long enough to contain the candle and allow some room for it to burn. So that is my suggestion. I have seen several labs that don't have canisters that have makeshift containers, but it has a cover that can allow the oxygen to be used up. And also for the chromogenic agar, it virtually works, even though it just eliminates the identification of the bacteria. So let's say you have chromogenic agar and clade. On day 1, when you plate them, day 2, you will come, clade will have the bacteria without identification. Chromogenic agar will have bacteria with a name, but you still have to do sensitivity testing. And the clade, you are doing sensitivity testing and then identification on the same day. So on the 3rd day, you will have results for the clade and the same as chromogenic agar. So what the chromogenic agar does is it eliminates buying extra media and doing extra tests, but the number of days is still the same. Thank you.
All right, so thank you very much, Doc. Pierre Charles, can you take your question?
Yes. My question is with regards to diagnosis of pyuria at the bacteriology lab. In your presentation, you said it is not advisable to use a span urine. So I want you to throw more light on that. Why it's advisable to use unspan urine? And then my second question is with streaking. I came to meet this this continuous streaking, the Christmas tree type of streaking, and then I don't know why that streaking was adapted for urine culture. And also, is it advisable to flame in between when using that continuous streaking? And also, yes, I think I've exhausted my questions. So I have 3 questions.
Okay.
Thank you very much.
So like the name says, continuous streaking, you don't have to lift the loop. You just calm down, go back up, and streak out so you get your isolated colors. And you asked about centrifuge. So for the urine, we want to catch whatever is there. We want to see parasites. We want to see whatever is there. But for the culture, we don't want to disturb the urine. We are saying that if you have 10 white blood cells in an unspun urine, it is abnormal. It is suggestive or indicative of a urinary tract infection. So if you have, let's say, a urine with 10 white cells, and you have another urine with 20 white cells, you spin the 10 white cells and you pick the 20 white cells. There'll be difference in whatever you see under the mic. The spinning will misinform you. You may think you have more white cells in the urine than normal. So for urine culture, you are picturing the bladder. What is happening in the bladder now, undisturbed? How many white cells are there? Undisturbed. And that will let you know that something is good. But you may have urine with just a few white cells. In the undisturbed state, you have a few white cells. But when you go and spin it, you concentrate it and get more cells. It may misinform you that there's white cells, high white cells. So ideally, for urine culture, you do not centrifuge the urine. You use the unspun urine and you do your wet preparation. Thank you.
Thank you very much, Doc. Dr. Francis, Pache Antwi.
Yeah, thank you so much. Dr. Dennis, am I loud and clear?
Very pleased. Go ahead.
All right, so Dr. Esther, I wanted to find out, our clinicians who don't give us clinical information about the patient, how do we, number one, know whether the patient has taken some medication? If you can throw light on the test we can do to really confirm the patient is on medication. And then with the sample sitting on the bench, I think that in our various labs, that would be a suggestion. We need to do more about it, because if you come to, let's say, the bigger hospitals where samples are batched before they are plated, I think they spend quite a number of time on the benches before they are plated. And then I don't know, my final bit would be from experience, most of the unspun samples, urine samples that are captured, those that you'll be getting PC parcels of 1, let's say RBC 0, epithelial cell 1, most of them will give you significant growth as compared to some of them that the parcels may be more than 5, 6 thereabout. I don't know whether there's an explanation to that, because in practice, that is what I have seen so far.
Thank you very much. Yeah. So for your last question, if I got you right, white cells are low, but then there's bacterial recovery. Is that what you are saying?
Yes, so there's a significant growth, even though the parcel is just 1 per a high power field, epithelial cell 1 per high power field.
Yes. So like I was talking about asymptomatic bacteria, you always have to interpret the lab report with the patient, the signs and symptoms. So this sample will be a sample without, that wouldn't have even grown. But for keeping the sample on the bench for a long time, you have allowed the bacteria to multiply and you are getting a false positive. Okay, so that could be an example of having low pass cells with a lot of bacteria growing. For the checking of the medication, there's an archaic test where you use Bacillus subtilis. And then, so if the person has taken antibiotics, that's if the doctor doesn't write. Ideally, he should write the request on the form for you, the information that this patient is on this drug. But if you pick the urine sample and you inoculate it in the presence of Bacillus subtilis, you will know whether drugs have been taken or not. Thank you.
All right. Thank you very much, Doc. So I'll quickly want to resume and take some other questions. Now I start from the YouTube page where I have Emmanuel Agbesi Jandu asking what is the appropriate sample for N-gonorrhea diagnosis in females?
Okay, so for that, a urethral discharge that is collected properly, because for the high vaginal swab, in the vagina, a lot of epithelial cells are sloughing. And so when you take your samples and you don't take them properly, you have a lot of epithelial cells occluding whatever you may see in your gram. So for females, a high vaginal swab
I can't hear.
properly collected by a trained should be ideal for Neisseria.
All right. Doc, thank you very much. So Esther Irenchua on YouTube is asking for the name of the facilitator. I need to see her. So that's Dr. Esther Okan. So Doc, maybe you can at this point reiterate where you work, your full name, so that some others on the call can contact you. Hello, Doc. Hello, Dr.
Yes, sir.
Yeah, so whilst answering this question I'm going to ask, you can reintroduce yourself and your facility so that others will get to know and know when they could contact you. Is there a database for assessing AMR data in Ghana? Dr. Okan.
Hey.
Yeah, Dr. Okan.
Yes, Doc.
Do we have a database for assessing AMR information in Ghana?
For our what?
AMR, antimicrobial resistant data. And this is coming from John Baptist, Doche Kwame. So Doche K. John Baptist. Is there a database for assessing AMR data in Ghana?
Okay. So in Ghana now, most of our data is churned into a glass or international database systems. I think Fleming is now working out in conjunction with some of the hospitals to start gathering national database to inform decision making. So for now, if you want to get information on AMR data, you won't have any from Ghana, but from the international, like example, like glass. Thank you.
All right. Thank you very much. And
I need to add to that, so one of the main reasons is there's a need to examine, inspect what people are doing in laboratories in the terms of AST. Are they conforming to CLSI guidelines? Because if we are going to put all this information into a database, we should have standardized procedures or protocols that everyone is following so that we know the data is truly correct. Thank you.
all right. So Emmanuel Insifo is asking whether you have to perform cell count on aspirates.
Yes, Mr. Emmanuel Insifo, when a doctor requests for cell count, it is done for aspirates. Aside that, gram is routinely done. Thank you.
All right. So Agama Kofi Peter, I think your issue is about not having the clinical history for requests that come to the lab. Please make sure you get that information. It's only by that will inform some of the things you have to do. You may have to go to your clinical meetings as well, make presentations, let them see the need and what you use the history for so that they will subsequently be providing it. But it's quite difficult for you to interpret lab cultures without the history. In fact, at times it guides you to know what to do, the kind of sensitivity you may even want to do to help the system. So attend meetings, make presentations, request for the information that is required to perform your test as lab scientist. Okay, so I think there is an issue about diabetes and candida. Others have made comments over there, so people can read through it, but I think it's all about possible immunosuppression to have candida in the urine of the people. Okay. I don't think I have any other. Is it appropriate to culture urine on only BA or CA in cases where you don't have cled or McConkey?
Okay, so if you culture urine on BA, you may have challenges in differentiating the gram-negative rods. And also, let's say if you have 2 gram-negatives growing and their colonial morphology is not too different, you may think it is one bacteria on blood agar or chocolate agar. But with your differential media, you can really identify them. So try and get it. If you don't have McConkey, then you have to culture your urine on a full plate so that you will get true isolated colonies. And when you culture gram-negatives, you have to pick them up and do your triple sugar to know the fermentation of the sugars to help you identification. Thank you.
Okay. So Kofi Mensah has a question, but I think you have touched on it. How you may want to report on your sensitivity. And he wanted to know whether you want to find out the available antibiotics in the pharmacy before you may want to report. I don't know if you may want to go over the processes of reporting your antibiotic sensitivity.
Okay, so it is sad because getting antibiotics in the lab is now becoming a bit difficult. So what is procured? There is no streamlining between what we procure to use for our sensitivity with what the pharmacists are also procuring. So sometimes we have a drug that we have tested in the lab, it is working, but we don't have them on the pharmacists. I think hospital institutions or the leadership should make sure that when we are procuring some of these antibiotics and what we use in the pharmacy, we can really align and say, if I test for vancomycin, I can get vancomycin to treat my MRSA. Thank you.
All right, thank you very much. So maybe let me see. GS, How are we doing with time? Maybe I can take these few ones. And Samuel Amwako Dako. Growth uncleared gave no bacterial growth. Past cells greater than 30 per high power field in urine area, and direct wet prep gave 14. Beyond sterile pyorrhea, what other possible explanation can be? I wish some of these, Doc, you want to take a look at it, but these are questions that we can always flash on our WhatsApp platforms and get colleagues to also discuss and give possible suggestions, because it might not just be, you may want to also give more about the clinical presentation that you got in the lab to help others make informed decisions and give possible outcomes. But Doc, would you want to give some explanation?
No bacterial growth uncleared. White cells.
Greater than 30 per high power field.
And
in the area.
And then
the direct wet prep was 14 per high power field. Okay.
So it could be so many things. One, is your media correct? Two, it could be uncontrollable bacteria. It could also be trauma leading to the high white cells. So you need to get some information from the clients to be able to make interpretation. Like I said, you always compare your results to the signs and symptoms before you can interpret them. So it could be media that is not working well, or it could be as a result of trauma or unculturable bacteria, like even tuberculosis of the urinary tract. Thank you.
All right. Thank you very much. Beatrice Azavu, I requested you put your question in the chat. Unfortunately, you didn't do that. I don't know, you still have your hand raised.
Please, I didn't see.
You were not clear.
Please, with one of my questions, I was asking if when you have a past specimen, can you do the white cell count or cell counting?
So if you have a past specimen, you do your gram. On your gram smear, you can report whether you are seeing polymorphs, whether you are seeing bacteria, whatever you are seeing, you can report it. Because past is usually thick, it's an X date, it's usually thick. So cell count will be difficult. It means you have to do some dilutions. So usually for past, you count your white cells from your gram smear. Thank you.
Okay.
All right, thank you very much. So,
please, I wanted to make a contribution.
Okay, go ahead. Before
currently with the limbs we are using, you can, those who are having issues with getting the patient information, you can see your IT department. There is a way of accessing every information about the patient history in the system. So those who are fortunate to use the limbs can get every information they need about the patient in order to make judgment on laboratory results. Thank you.
Right. That's good information, but take note that you only deal with what access you have. So if it's required, please make the case so that it's added to your level of access in the limbs. There are a whole lot of issues about data protection in Ghana. So make a justification of why you need access to that part of the patient records so that the ITs don't give you any priority when in actual fact, you don't need it. So it's a very good information, but please always make a case. If your access is required to have that, please, it must be extended to all. So there is not only a few who know the IT person may have it, because data security issues are at hand, and one day you may be caught at a site that you are not happy with. So please always make a case, make the request, and I think it has to be extended to everybody who needs it. Thank you very much, Doc, and DS, kindly come on board and close the session.
Yeah, so good evening, PRO and GS and all the teams behind the scene. Dr. Okain, we thank you so much for the education and then the information you've provided. I believe that most of our members will be getting in touch so that they can tap on the experience that you have shared today. We want to thank members for their continuous support, and we hope that we will continue to show our presence. Like we indicated, it's not as if it's going to be a wholesale. We will just ensure that those who participate are those who will present, even though it's free for all members, but it's also a requirement that we are supposed to learn. And so you can't sit somewhere and expect that we'll give you CPD without learning. So please inform others to make sure that they join so that and watch also and participate in the program and help the program to be able to move to a higher height. We still encourage members to continue to visit the YouTube and then watch Gamls TV. At least we need to hype it and give it more viewing, what you call it? What's that answer? Views. Yes, views. All right. So thank you all once again, and let's continue supporting each other. And I hope that the profession will go places. In fact, this shows that we have a lot of human resources. We have very wonderful and great members among us. And so henceforth, everything is going to be internal because we have the men and women who can assist us in being able to achieve the things that we want for ourselves. So thank you, Doc, and thank you, every member being here. Have a lovely night.
All right, PRO, thank you for the work you are doing, and thanks to all who are behind the scene making the program successful. Dr. Okain, thank you very much. So PRO, I'm done. You can we can end if we have nothing to add.
Okay. So thank you very much, Dr. Okain, for your time. And thanks to all colleagues for being on the call. Those listening in on the YouTube, we thank you. We will urge all of us to subscribe to the YouTube page, our Twitter page as well. Go and follow so that we can keep us moving in the social media space. We meet again tomorrow at 5 for another brilliant session. Have a good evening.
Have a good evening.
Thank you.
Good evening.
Thank you very much. And